Hey everyone, I'm going to try and do a little bit of voiceover animation for the slide that didn't work in class yesterday. So here goes. Running in PowerPoint now. So this is regarding the piece about kind of the theory behind how we do renal dosing or adjustments in renal doses or in doses for patients with renal insufficiency. So here's the graph. I talked a little bit about, so if we think about a patient who's receiving a medication, a particular medication, and they have normal renal function, then sort of at steady state we would see this peak and trough, here sort of being the peak, here being the trough, and really CSS average running through the middle there. So that would be sort of normal at steady state, nothing really going on. If for whatever reason this patient started to develop renal insufficiency and their their filtration rate or the creatinine clearance started to go down, what we would see is sort of what's here in this red dotted line, but what we would see is sort of a decrease in the rate of elimination. So we can see the line or the dotted line between the peak and the trough starts to get a little bit more horizontal, letting us know that the rate of elimination is slowing down, as well as then accumulation then starts to happen. So over time we get to a new steady state. Here's our sort of our new steady state with our peak and our trough both elevated compared to the peak and the trough of a patient with normal renal function. So this would be in that patient with renal insufficiency. And for the most part, we kind of don't want this to happen. So what we would like to do is try to develop a dosing regimen that gets us closer to what normal looks like. So the two ways we really talked about is reducing the dose. So if we reduce the dose, what effectively we would be doing, shown here in the green lines, is that we would be reducing the dose, and so both the peak and the trough is now decreased compared to what was in renal insufficiency. So here, the peak and the trough for the red line represents renal insufficiency. So we decrease the dose, and what then happens is our peak and our trough completely lowers. But compared to a patient with normal renal function, which is that purple line in the background, we see that our peak is actually less, but our trough is actually more than what we would expect to see with a patient with normal renal function. And at the same time, the CSS average, or our steady state plasma concentration average, remains pretty much the same here. So peak lower, trough higher, but CSS average is the same. So that was the reducing the dose option there. So we talked about sort of one of the problems with this is that if our therapeutic level we needed for efficacy was really up here, and we needed a higher peak, then this option wouldn't necessarily work for us. Likewise, if toxicity occurred at a higher trough level, then in theory our trough is going to be much higher, or it is higher here in this scenario with the reduced dose option. So the other option that we talked about is really the extended interval dosing, shown here in the orange. And we talked about the thing that was good, or why people sort of prefer the extended interval approach, is that the peak and the trough remain the same for the extended interval approach. It's just the time between them is longer, as sort of the name implies. So we extend the interval to take into account the decrease in the rate of elimination, or the filtration rate that's happening in the patient with renal insufficiency. So we end up with the same peak, the same trough, and with that the same CSS average. So we talked about the main limitation here with this particular approach is that the timing for CSS, the timing that a patient remains below CSS average is actually extended. So here, if we follow the orange line between CSS average and the trough, the time between these 2 points is 12 hours. Whereas if we look at the patient with normal renal function, from CSS average to the trough, that time is approximately 6 hours. So that's how the time below CSS average might be extended. Now the problem with that, and this is probably not true for most medications, but the one that I think about the most are some of our antibiotics are called or considered to be time-dependent killers of bacteria. And so what that means, and Dr. Jordan will talk about this more in infectious disease, but what it means is that the medication requires the drug itself should be above of the minimum inhibitory concentration, or MIC, for the majority of the dosing interval. So the preference there would be for the drug level to be above the MIC. And so if we think about CSS average as being maybe the MIC of a bacteria, so that concentration in the blood that we need to attain with our drug to kill the bacteria, what that would basically be saying is that for half of this dosing interval, we wouldn't have enough drug in the body to inhibit continued growth. So instead of just 6 hours that the bacteria would have to replicate again, now we're saying the bacteria would be having 12 hours of time below the MIC for that bacteria. So that's sort of one example where it could be important, where the extended interval dosing could play an important role or importantly affect the efficacy of the drug. So hope this animation helps a little bit in explaining the differences in the reduced dose versus the extended interval dosing. So you can sort of listen to this over and over again, or as always, come and talk to me if you need some clarifications on the topic. So thanks for your attention, and yeah, let me know if you have any questions.